Can you hear me now?
Yes, madam.
Yes. So we are going to learn today the motor system examination. So motor system examination, there's nothing called like separately that somebody is going to examine the motor system of a patient. It is in a very rare instance it might be needed, but usually motor system wise we are usually doing, like for example cranial nerves. If you want to do motor cranial nerves, sometimes the examiner in not at your level but in your final exam, when you're a 5th year student, they will ask you to do motor cranial nerves examination, right? What are the motor cranial nerves? If somebody asks you to do a motor cranial nerve examination, when you start from first nerve, cranial nerves, what is the first cranial nerve?
Olfactory.
Yeah, is it a motor or sensory?
Sensory.
It's sensory. What is the second cranial nerve? Yeah, is it sensory or motor?
Sensory.
It is sensory, right? Okay. The third one is the oculomotor, right? It has a motor component. So it can be examined together with the eye movements, right? What are the nerves involved in eye movements? Which motor nerves?
Oculomotor,
Oculomotor,
trochlear, abducens.
trochlear and abducens. So that is third, fourth, sixth nerves we are examining together. So they are motor. And then what is the one remaining? Trigeminal nerve, fifth cranial nerve. So trigeminal has one motor component where you check the masseters and certain muscles supplied by the trigeminal nerve, right? You will learn these things when you're doing the cranial nerve examination. So I'm not going into details. And sixth is abducens, seventh is facial. Facial nerve also has a motor part, right? So you will learn with time how you are going to examine for the motor part of the facial nerve. And then eighth cranial nerve, vestibulocochlear, it doesn't have any motor part, it's sensory. And then comes the ninth cranial nerve, glossopharyngeal. It's mainly sensory. There's a small part which is motor, but predominantly when you check the gag reflex, you are examining all these muscles like 10th cranial nerve as well. And then 11th is the accessory. So you are checking sternocleidomastoid and shrugging the trapezius muscles and so on. So you are checking accessory nerve in that way. And then comes the last cranial nerve, hypoglossal, which can be examined by the tongue movement. So that is, you are doing the cranial nerve examination. So then what I'm going to teach you today is how you are going to do the motor part, motor system examination of upper limbs and lower limbs, right? So let's first, I'm going to share my screen.
Recording in progress.
Okay. So yes. So we are going to start with neurological examination of the upper limbs. So when do you need to examine the upper limbs? For example, for like ideal world, we should examine all the patients coming to us. We have to examine their upper limbs, right? But since we are busy and we don't have that much of time, what we usually do is, if they are coming with kind of neurological complaint, we do an upper limb examination. For example, if they tell about a weakness of a limb, not only upper limb, if they have a weakness of the lower limb also, we have to examine the upper limbs. As well as, for example, if you see a facial nerve palsy or a facial asymmetry in a patient, then also you have to do a upper limb examination. So, for example, when you suspect a patient to have a neurological issue, then you are going to examine the upper limbs. So, if you are examining somebody's upper limbs, what are the most important parts? So, you are going to examine their motor system, you are going to examine the sensory system, and then you are going to examine the coordination, right? I think you have already done sensory system, how to examine sensory system with Prof. Sampath Gunawardena. So I'm not going to tell you about how to do the sensory system examination, but how to do the motor system and coordination means basically cerebellar. And how to do upper limb part of these motor and cerebellar examination. So let's start with the motor system examination. So if you have learned already the cardiovascular system examination, what are the most important 4 parts in examination? Can somebody tell me? Like if you like basically categorize the cardiovascular examination, remember? No. You started with inspection, right? What is inspection? You are just looking at the patient, looking at the thoracic cavity, like the upper part of the body when you are starting the cardiovascular system examination, right? So that is called inspection. And then you go and do what? Palpation. You are going to palpate for the apex D, right? And that is, and also palpable murmur. So that is how you did the cardiovascular system examination. First you did the inspection, then you did the palpation, then you did the percussion. Remember percussion? Yes, you're looking for the resonance, dullness, those things. That is percussion. But you have not done this usually in cardiovascular system. But if you remember respiratory system, you have done percussion. So usually any examination we call that we are starting with inspection, then going to palpation, then percussion, and then last thing is the auscultation. That is how we did the system examination. But in neurology examination is a bit different. What we first do is inspection. Then we are going to assess the tone, and then we are going to assess the power, and then we are going to assess the tendon reflexes. Right? Remember? First inspection, second tone, third power, fourth tendon reflexes. Right? Let's see how we are going to do these 4 parts in upper limbs, and then we are going to learn how we are going to do these 4 examinations in lower limbs. Right? But cranial nerve examination is quite different. You will learn later that this sequence is not there in that neurological examination. So if you start with, if you could remember what is inspection. So I already told you inspection is you're going to see, like you are going to observe without touching the patient. Right? If you want, you can just touch, like not like in the purpose of examining, but just you can touch the patient. But it's like basically you're looking at the patient. What's in the body? What are the changes, right? And then what is tone? Tone, I told you in my lecture as well. Tone is some resistance towards passive movement. So you ask the patient to relax, and then you are doing these flexions and extensions and see what is the resistance you feel, right? That is tone. And power is, you know, the power. So how much power they can elicit against you. For example, if you are asking him to extend like this from the elbow, what is the power? You should be able to assess that. For that, you think that your power is normal. That's one thing. And the other thing is you have to examine so many patients to understand the normal power, normal tone of a person. Right? And then tendon reflexes. We learn how we are going to elicit tendon reflexes. Right. So to start with inspection. So what are the things you are going to inspect in a motor examination of upper limbs? Right? So you are going to see whether the patient, first you have to expose the patient properly. So if you are examining the upper limbs, right, for any system examination,
Recording stopped. Recording in progress.
Can you see the screen?
Yes, madam.
Okay, yeah. Something happened. Right. Okay. So first what you're going to see is, like I told you, first is the exposure is the most important thing. So how to expose? You have to expose the bilateral upper limbs properly, anteriorly and posteriorly, and at least up to the upper chest wall, there should be a good exposure. And then you are going to see the patients from front and from back to see whether there's wasting. So which wasting you are looking at? You are looking at whether there's a proximal muscle wasting. What are the proximal muscles? Yes, here this deltoids, these most proximal muscles, whether there's wasting in the proximal muscles. And then you're going towards distal sides as well, slowly, and see whether there's any wasting. Ask the patient to keep the hands like this, right? And see whether you can see any wasting, right? Can somebody answer this question? Which muscle wastes first in small muscles of the hands? Which place you can see first the wasting? Anatomy, not physiology. Anybody knows the answer?
Is it the thenar muscles?
Sorry?
Is it the thenar muscles?
Not really. It's first this, first dorsal interossea here, right? This is the first muscle usually is getting wasted, right? Dorsal gut ring and first dorsal interossea. So how you know? Just you have to see all the patients' hands as one thing, just like see after seeing the patients with experience, and you can compare the sides, this side and this side. If there's bilateral wasting, it's a bit difficult, but otherwise you can see some dorsal wasting. And then you ask the patient to show the other side of the hand and look at the thenar and hypothenar eminences, right? And then if there's wasting, then you have to look for fasciculation, very irregular type of contractions, movements, fasciculations you have to see. And then look at whether there's any limb deformities, like wrist drop, right? Or claw hand, right? Look at those deformities. And then some patients have involuntary movements. What are involuntary movements? So our movements could be very purposeful. For example, I want to take my phone, I know what to do and take it to my ear and everything. And some patients have very involuntary movements of the hand. They are going very haphazardly everywhere. So it is involuntary movements. And sometimes some may have tremors and things which are really involuntary type of movements. So you have to observe them and report it while you are doing the inspection. And the other most important thing is the pronator drift. Right? What is this pronator drifts? What is pronation? So this is supination and this is pronation. This is supination. This is pronation. So what is pronator drift? So this is an examination I like the most, which gives you very good information about a very minor or subtle weakness of a person's hand, right? Upper limbs. So you ask the patient to keep the hands like this and close their eyes, right? To keep the hands like this and close their eyes. And when they close their eyes, their hands sometimes slowly pronate and come slowly downwards like this. It's a very subtle change. So this is very important when some patients come with stroke, right? And they come like 2 to 3 weeks later and their weakness is now almost settled and you can't see apparently by looking at them, by checking power and things difficult to assess. But if you do this test with this pronator drift, you can identify there's a weakness of this upper limb. So it can check mainly, the pyramidal weakness, right? Upper motor neuron type of weakness, but sometimes it will wasting also there can be some pronator drift, but we call this pronator drift and it is checking the pyramidal weakness, right? So there are 5 things basically if I do upper limb examination that I usually do, but there are certain other things that people might do. So these things are related to the motor system. But if you have done the sensory, there are certain things in sensory system also you are looking in inspection, because upper limb examination is the whole thing. Motor, sensory, coordination, everything. So for the sensory system, for example, you can look at the patches, which doesn't have any sensation, those patches. You see sometimes in leprosy, and those type of things are important, and palpable nerves and things in leprosy. So when I do all these things together for motor system, for inspection, I usually do these 5. This is muscle wasting, fasciculations, limb deformities, involuntary movements, and pronator drift, right? So before going into the video, I'll show you some pictures of pathological things here. Right. Let's see who is able to tell me what are the issues you can see in these inspections of the distal muscles, so bilateral hands. Okay, what is this? What can you observe here? Can someone answer? Anything you can observe in these hands? Yes? Very good. Where? Which hand?
Right hand.
You have my problem, right? Right and left issue. So this is yes. No, not left. Huh? You are telling patient's hands, right? Not looking from here. You have to tell patient's side. But which side? Right side, isn't it?
That side.
Yes. You can nicely see the first dorsal interossea is wasted here, right? Compared to this side, this bulb. So I told you this is the first thing to go usually when there are small muscle wasting. Here also there's some guttering, right? I don't know whether he like the way they are keeping the hand, but you can nicely see it here, right? There's dorsal guttering. Here, what can you see?
Tena wasting.
Yes, that's bilateral tena wasting. Example for this, who usually get these type of things? Tena wastings. Median nerve? Yes. Carpal tunnel syndrome? Yes, right? Carpal tunnel syndrome, you get a median nerve compression, and usually median nerve palsies, you see these, what is called tena wasting, right? Here you can see a bilateral issue, bilateral tena wasting. What can you see here?
Underfloor.
Yeah, maybe, but the most prominent thing is you can see a hypothena wasting, right? So hypothena wasting is usually associated with what? Hypothena wasting is associated with?
Ulnar pulse.
Yes. And also, but this hand, maybe there's some tena wasting as well. So this is like kind of bilateral small muscle wasting, usually seen in which roots?
T1.
Very good. C8 and T1. If you tell T1 also, I accept it as an answer. C8 and T1 both involved when you can see both tena and hypothena eminence are wasted. And this is the ulnar claw you have told me, right? You can see it is a little bit flexed here, but extend here. And so this is the usual appearance of an ulnar claw. Right. What can you see in this gentleman?
Proximal wasting.
Proximal muscle wasting. So proximal muscle wasting usually seen in, this, in the muscle diseases most of the time, but you can see in neurological diseases as well. But it is common with muscle diseases like shoulder, scapular girdle dystrophies, and any kind of myopathies. Usually they are associated with mainly a proximal type of muscle weakness, right? Okay. So let's go to the videos. So I have to tell you one thing about these videos. I'm going to use Colombo Medical Faculty examination videos, right? Which I have also used as a medical student as well as when I was doing postgraduate study. So they are really good. So if you want to refer to it, like see videos hereafter, cranial nerves, upper limbs, lower limbs, anything, I recommend you to watch Colombo Medical Faculty videos. Now they are in the YouTube, right? And the only issue is they are very poor quality. They are very old videos. So, just refer. I would like to recommend you that, and I'm going to use them to teach you as well, right? Can you hear me?
Yes, madam.
So this is Dr. Piyusha Pattu. She's a neurologist. She works in physiology department, Colombo Medical Faculty. So she's going to describe you how to do upper limb examination, and I'm going to interrupt time to time to get some feedback and to teach you certain things, right? Okay.
This focus, that inspection and testing of muscle power, and finally the test of deep tendon reflexes. For examination, you have to show that the upper limbs are well exposed as well as the upper
Excuse me, madam.
Yes?
It's very important.
We can't see the video.
You can't see the video?
I don't know.
Okay, let's try again. I have shared this. Can you see it now?
No, madam.
No, madam, not yet.
Can you see the video?
No, madam.
No.
Recording stopped. Recording in progress.
Can you see the video now?
Yes, madam.
All right. Just tell me if you can't hear properly, then I can tell you the things, my version. But I think it's better to listen to what she's telling.
The examination
We can't hear, madam.
You can't hear. Okay. So I'll tell you. So she's telling the 4 components of the motor system examination, which I told you already. That is inspection, tone, muscle power, and then reflexes. Right? Can you see the video? I have paused it. Can you see it?
Yes, ma'am.
Okay, right. Yes. So she's now telling about the exposure, right? Now see how she has exposed the patient. So it's all the upper trunk as well as the upper limbs are exposed. Now she's looking at the wasting now, proximally and distally. Look at her, she's looking at the dorsal gutturing, whether it's there. And turning towards the other side, looking at the thenar and hypothenar eminences. So can you see it here? So she is showing some fasciculations. right? This is another patient of the same person, that is fasciculations. And then she says to observe for involuntary movements like tremors and other involuntary movements. So for mild weakness, you can do the pronated wrist. Now she is showing how to do the pronated wrist. If the hand has a weakness, then you can see that type of a drift of the upper limb. Okay. If you want to see that again, I'll tell you what she has seen, right? She just exposed the patient, right? And then she checked for the wasting, both proximally and distally. And if there's wasting, then have to check for fasciculations. And then she looked for pronated drift as well, involuntary movements. And those are the things basically you can do in the inspection part. Now after inspection, where are we moving to? Then we are moving to check the tone, right? And what is tone? I told you tone is what you're going to elicit. The like when the person is relaxed, right? Somebody is doing passive flexion and extension. And then you feel what type of resistance you can feel. In a normal person, there are some resistance. And if somebody has an increased tone, that is spastic, in upper motor nerve lesions, they are very spastic and difficult to move, right? And if somebody is very flaccid like this, it indicates that it is a lower motor neuron type of lesion. And then if somebody is spastic, you have to tell whether the patient has which type of rigidity, right? The type of rigidity can be either what is called clasp knife. You know the clasp knife? The clasp knife rigidity, that is just like a clasp knife. When you are in a spastic person only you are doing this. When you are moving this like this, first it's very resistant and then suddenly it gives way, just like a clasp knife, right? And you can see these things in pyramidal weakness, so upper motor neuron type of weakness. And there's another type of spasticity that you can elicit in patient, which is called lead type spasticity. So in lead pipe type, you know the lead pipe? Right? Lead pipe is always rigid. It doesn't give way. Throughout it is same spasticity, right? Same type of lead pipe. So that is seen in patients with Parkinson's disease. And other than that, they have what is called cogwheel rigidity. That is when you move from the wrist, right? You can see how she's doing that. Rotate from the wrist. Then it is going like tuk, tuk, tuk. Not like very smoothly like this. From place to place, moves like this. Not sound, right? It's very rigid, going in a very non-smooth manner, right? That is called cogwheel rigidity. So cogwheel rigidity and lead pipe rigidity are seen in Parkinson's disease patients, right? Let's see how she is going to examine for the tone. Muscle tone can be normal, increased or decreased. If the muscle tone is increased, you have to check whether it is clasp knife rigidity or a lead pipe type of rigidity. First ask the patient to relax. And now we are going to move the bend and extend the elbow. And then you can have to pronate and supinate from the forearm, right? Then test for cogwheel at the wrist. I told you cogwheel. Right. See how she's doing the cogwheel. And then you have to check whether the spasticity is, if there's spasticity in the patient, whether it is lead pipe type or whether it is clasp knife type of rigidity. Right? So always you have to compare both sides. There are two sides. When you are doing the movements, do this and do this and check whether there's any difference between two sides. For example, one side it will be spastic, other side it's normal. So you have to appreciate that. So you have to check all these things, whether there's cogwheel rigidity, and if the patient is spastic, whether it's kind of clasped or very rigid throughout the movements like lead pipe, right? Now moving into muscle power, right? So muscle power has to be checked in all muscle groups, right? So muscle groups like from the shoulder, elbow, wrist and the small muscles. So when you're checking, you should have an idea about the roots, like this is C5, this is C8, this is C7, this is T1. So you have to have an idea and always compare either sides of the patient. Then you can get an idea, okay, this side it's weak, this side it's normal, this side it's spastic, not spastic, sorry, this side it's different, like it's always weak or normal, right? Not spastic, flaccid or anything, it's weak or normal. And then you have to document properly, this patient has weakness of these muscle groups, right? Let's see how she's doing that. And first we have to, when you are doing the muscle power, it is important to grade the muscle power, right? So how to grade the muscle power? So you have to first think that your muscle power is normal and then you are doing the movements of the patient, right? For example, okay, you are extending the elbow and you have to feel the patient's muscle power, right? So when you are feeling the muscle power, the grading is usually there are 6 grades starting from 0, 0, 1, 2, 3, 4, 5. So if it's completely normal power, if you think, for example, if somebody has a normal power, you can't resist their power usually, right? For example, if they are extending this hand like this, and if you are going to resist that power, in a normal person, you would not be able to resist the power. It will stop somewhere like this, right? So if you can resist it and do this, then it's not completely normal power, right? It's a slightly reduced power of that patient. So if it's 0, if you are document the power as 0, then there's no movement at all, right? And if we are going to document the power as grade 5, that means it's completely normal power. You think you have complete normal power and the patient has completely normal power. And then grade 4 power is the patient has a power, but it is reduced. However, they can move against resistance slightly, but when you put the resistance, they can move against the resistance, but it is reduced power. And then grade 3 is the patient can move against gravity, but not against resistance, right? So they can lift up a limb like this against the gravity, but if you keep the resistance, they can't move against the resistance at all, right? අත තිව්වම උස්සන්න බෑ. අත තියලා මේ අතට එරෙහි උස්සන්න කිව්වොත් බෑ. හැබැයි තනියෙන් උස්සන්න පුළුවන් against the gravity. That is grade 3 power, right? And then what is grade 4 power? They can only move if the gravity is eliminated, right? Now she is showing how to eliminate. So now the movement is against the gravity. Can you see? Now you can eliminate the gravity like this. So this movement is against gravity, right? Just see it again. That movement is against the gravity. So now there's no gravity. The gravity is eliminated for the same movement, right? So some patients are unable to do this, move against the gravity themselves, but if you eliminate the gravity, they can move slightly, right? And the grade 1 is just a flicker of movement. They are trying to move, but nothing happens. You can just see muscles contracting, but no movement at all. Right? Okay. Now see how she is going to do the examinations from the shoulder. So what are the movements from the shoulder? Can somebody tell me the movements from the shoulder? Just to see whether you are still awake. What are the movements from the shoulder? Are you with me?
Elevation.
Sorry?
Elevation.
Okay, what do you call that? You are not doing like this, right? What is that? Elevation,
Abduction.
abduction, isn't it? What is this movement? Tell me. What is it?
Abduction.
What is this movement?
Adduction.
Abduction. What is this movement?
Lateral rotation.
External rotation. What is this movement?
Internal rotation.
What is this movement? Come here.
Flexion. Section.
What is that?
Extension.
Extension. Okay, let's see how she's going to do that. So if you do a very nice examination, right? You can like, you ask the patient, okay, you abduct. Right? That's what we usually do. Okay, you do the abduction. This is your hand, this is patient, this is your hand, this is examiner's hand for the time being. Asked to keep, you are keeping the hand like this, are now extend. This is also correct, right? We are checking now the power of abduction of the person, right? Power of the abduction you are checking like this. But it's very nice if you can keep the hand. Ask the patient to take the first movement. Okay, you keep the hands like this, right? Now you are going to move this way and ask the patient to keep the hands from the same resistance. Patient කියනවා මෙහෙම කරගෙන ඉන්න කියලා. මම ඔයාගේ අත මේ පැත්තට තල්ලු කරන්න හදනවා ඔයා තද කරන් ඉන්න. So the patient is trying to abduct, you are going to adapt. අනිත් පැත්තට ඔයා තද කරනවා මේ පැත්තට. Patient is trying to abduct. Right? එහෙම abduction බලන එක තමයි it's the nice way. අර මෙහෙම patient මෙහෙම තියන්න කියලා මෙහෙම කරන patient අත් රිදෙනවා and it's not very nice. So it's also correct. You can do it in that way as well. But the most the best way to do that is ask the patient to take the first movement, ask them to abduct. තවත් abduct කරන්න නොදී ඔයාලට පුළුවන් තද කරගෙන ඉන්න. Let's see how she is going to do that. Okay. Okay, now she is trying to abduct a little and checking this. So this is checking the supinators, right? Supraclavicular nerve, that is C5. By what is doing? That is 30 degrees. First bit of abduction is done by the deltoid muscle. So this is, she is checking that one. First 30 degrees of abduction done by the supraspinatus muscles. Then okay, now she's abducted the hands fully. Can you see? She has to abduct the hands fully, right? See, very nice the way they are keeping the hands. It's very nice. Keep it like this. Keep your hands either sides like this, right? That is second 60 degrees of the abduction. This is done by the deltoid muscle, but responsible nerve is axillary nerve. Still C5. So you are going to check that part of abduction now. So you are checking always both sides and comparing. Now she is checking external rotation. So it's infraspinatus, C5. So now she is telling there are two other important muscle groups you are going to ceck from the shoulder. That is the trapezius muscle, serratus muscles and the latissimus dorsi muscles. So for that, what you have to do is, you have to ask the patient to keep the hands against the wall. And then you're observing from the back to see whether they have winging of the scapula, right? So serratus anterior, that is long thoracic nerve C567. So you are looking for the winging of the scapula, right? That is for serratus muscle. And then for latissimus dorsi, you have to ask the patient to keep the hands either sides of the hip. So not latissimus, that's rhomboids. And then check for the power, C5. Right? Sorry, I did two mistakes. So first one is serratus anterior. You checking serratus anterior by keeping the hands on the wall, right? And then check for the winging of the scapula. That is you're checking the serratus anterior. And to check the rhomboids, ask the patient to keep the hands like this, right, to the back. And then under the pressure, whether they can keep it like that. And that is, you're checking the rhomboids muscles, right? So now she's checking elbow flexion, C5, C6, biceps and brachialis, musculocutaneous nerve. Ask him to flex and then you're trying to extend and see the power. For extension, but she's doing it in the other way, ask the patient to extend and checking the power from this side. So it is C7. Right. Now she is checking from the wrist, the flexion and extension. Wrist flexion. See how she is examining that. Now checking the wrist extension. Mainly radial nerve. Right. So now we have done shoulder movements, the most important ones only, which have a value for the roots as well as the nerves, and then going for the flexion and extension of the elbow. And now we are going to the small muscles of the hand, right? So tell me, look at my hand, and can someone tell me what is this movement? What is this movement from the hand?
Abduction.
Abduction.
Adduction. This is?
Adduction.
This is adduction. So, hand like this, keep on the ground, right? Not like this. Keep on something, right? Or like, you can do it like this side. What is this movement? Against the ceiling, moving the thumb. What is this movement?
Abduction.
This is abduction of the thumb. This is?
Adduction.
Adduction of the thumb. Okay. Right. Let's see how she's going to do that. So the thing for this, you should have a Visa card or a, these pay phone cards or something, right? Just check what she's using. She's using that Food City, this loyalty card. So that is abduction. You are checking the abduction. Ask the patient to abduct and checking the power. Now for adduction, keep the card. Ask to adduct. And now check whether the patient can keep it like that. Right. Okay, now she is checking the abduction of the thumb. That is median nerve abductor pollicis brevis. That is opponents. Opponents pollicis. Right. Now we are moving to tendon reflexes. So what are the tendon reflexes you can elicit in the upper limb? So to elicit tendon reflexes, you should have a knee hammer with you. When you're going to third year, buy a good knee hammer, right? So good knee hammer, usually a bit heavy, right? It's a bit heavy, and there should be a good movement from the from here around this region. There should be good movement, right? So knee hammer. So where you're going to do, you can either do it in supine position or in sitting position for the upper limbs. So the reflexes you are going to check is here the biceps, and tapping here the triceps, and tapping here the brachioradialis, right? So when you are doing the biceps, you have to always keep the finger here. It's a bit painful. Just check when you buy one day the knee hammer, when you have a chance to check with a knee hammer, how painful it is to tap with this, right? So because of that, you have to always keep a finger on the tendon, right? You have to feel the tendon here first, biceps tendon, and then keep a finger over there, and then hit with the, or tap with the knee hammer. And then for the triceps also, triceps usually are not keeping a hand, but just slightly tap like this, right? And then for this one, you're tapping it here, right? Let's see, and always compare the sides. It is biceps. Just see the nice way she's keeping the hand. So you can do these things at home today if you have a knee hammer. So always keep a finger there, and then keep the hands in the same way and try to tap.
Keep the elbow assigned equal. Place your thumb over the bicep tendon. Tap the thumb. The first one, observe the contraction of the biceps as well as the flexion of the elbow.
So what are you looking at here? So you are looking here at the movement, the slight flexion movement of the hand when you are tapping here. And also you have to keep the hand exposed so that you can see the contraction of the biceps muscle as well, right? Now the triceps, you can see the contraction.
Support the patient's elbow and tap the biceps tendon.
You can see the contraction of the muscle. And slight movement from the hand.
Check the supinated jerk.
Now checking the supinated jerk.
Radialis tendon. Jerk of contraction of the brachioradial.
That is the radial nerve. Okay. So now you have seen how to elicit reflexes. Now we are going to the coordination. So the coordination is from the cerebellum. So coordination of the upper limb, what we are mainly doing is doing the finger nose test, right? To do the finger nose test, ask the patient first to extend the hand and then keep it on the tip of the nose like this. From the pointer finger. Extend, keep on the tip of the nose. From this hand and then the other hand, right? And if the patient has a cerebellar dysfunction, they can't usually point to the place. It's going past pointing, going here and there, right? Like this. And next you have to do, you have to give your finger and ask the patient to touch the tip of your finger and then the nose. And you are going to change the position and see whether they can do that. If they can't do that, it's going like this and coming back like this, then it is positive cerebellar signs. And the other thing is doing the what is called dysdiadochokinesia. Dysdiadochokinesia. That is, they can't do the rapid alternating movements. So what we usually ask is, ask the patient to keep the hand this side and then the other side. You can do it this way as well. Here, here, like this. Show the patient what to do and then ask them to do that. So you can do it rapidly. If they have cerebellar signs, they can't do it properly. And then the cerebellar signs are positive and their coordination there's an issue. Okay, let's see.
Coordination is tested at the finger nose test. It's diagonal kind. This is how we perform the finger nose test. Nani, Radhya, Kuppiya, Ilikuden, Alpudalla.
ඇඟිලි තුඩින් නාහෙ තුඩ අල්ලන්න. අනිත් පැත්තෙත් ඒ විදිහටම කරන්න. දැන් මගේ ඇඟිලි තුඩ අල්ලලා ඊට පස්සේ නාහෙ තුඩ අල්ලන්න. And the examiner has to move the position of the finger. This diadochokinesia, rapid alternative movements. Right. So I'm going to skip this part, sensory system, because you have already done that, right? So we are going back to our slides. Right. So you have seen the video. Muscles, okay. So then we learned how to check the tone. So the tone is checked. Ask the patient, "Pana nati karala inna." Right? "Pana nati karala inna." Then you are going to do passive. You are going to move the hands. Mehema, flex and extend. From here also flex and extend. And just compare two sides and just check the tone. Right? Kochara resistance ekak tiyanawada for the passive movements. And it can be normal. It can increase in a lead pipe way, like throughout the movement it's very rigid, or it can be clasp knife rigidity as in upper motor nerve lesions, that is just moving and suddenly gives way. And you know the reason. What is the reason for this clasp knife rigidity? Even we should have that, but in spasticity it is more prominent. What is that? Which reflex is involved?
Inverse stretch reflex.
What is the sensory organ?
Golgi tendon.
Very good. Yes, that is the reason for the clasp knife rigidity, and it is more prominent in upper nerve lesions because the inhibition is lost. And then it can be decreased, that is hypotonic, that is tone. Right? First we checked, we did the inspection, then we came to the tone. Right? And then we checked the power by comparing the two sides, and we did the shoulder first 30 degrees and then the 90 degrees, and then we did the external rotation, right? Not all the movements are necessary because you can do few movements and get an idea about all the nerves and roots. And then extension and flexion and extension from the elbow and from the wrist. See the way she did that? She just clenched it and then did the flexion and the extension. And then from the small joints, small muscles, abduction and adduction, and then she did the thumbs, abduction and adduction, and then the opponent's policies was checked. And then you have to grade the muscle power. Okay, this side abduction is grade 5, this side abduction is grade 4. Or this side abduction is grade 5 and this side abduction is grade 1, right? So you have to document all these things. And we have already discussed this, how to grade the muscle power and 0 to 5, right? And how to eliminate gravity for a movement. So you can do this movement against gravity like this, the flexion of the elbow against gravity. So if the patient can't do that, then you can help them by keeping the hand like this and eliminate the gravity and ask them, now do it. And now they can move. That means they can do the movements when the gravity is eliminated. But they can't do against the gravity, right? And this is the winging of the scapula. So which muscle is involved? Serratus anterior muscle. And you by standing up, you have to check the other muscle, that is rhomboids. You have to check it by keeping the hands on the hips and moving backwards. And then we check 3 reflexes: biceps, triceps, and supinator jets. Then sensory system comes the sensory system, which we have discussed already. Then the coordination, for which we did the finger nose test and the dysdiadochokinesia. Right. So how are you going to summarize your findings at the end of the examination? So you have to tell right upper limb, left upper limb, tone. For example, right upper limb tone normal, left upper limb tone is reduced. See how we are going to write this? Let's take a pen. Right. So we can say right upper limb tone normal. Okay. So just let's think that the left side, left upper limb is upper motor neuron type of lesion, and left upper limb tone is increased. Right? And power will be right upper limb normal, grade 5 out of 5. So you have to tell shoulder, elbow, and wrist, and small joints. So what do you have? Small muscles, the one you have examined, and write like this. Or even if you are very sure, you can say only proximal and distal, right? And this side, left upper limb, power is 2 out of 5, proximally and distal. And then the reflexes, right upper limb plus, usually we put is 2 plus when it's normal. The different people do it in their own way. Let's say this side it is exaggerated because it's upper motor nerve lesion we are suggesting. We can put it like this, right? Likewise for other reflexes as well. And then,
am I writing something?
sorry?
Are you writing something on the screen? We can't see.
You can't see that.
No.
Okay, maybe I need to take the whiteboard something. Okay, just I'll tell you again. So the tone, if you write normal here, you can put a arrow upwards and say that it is increased tone, right? And you can say power 5 out of 5 in this muscle group, but here it's 2 out of 5. Likewise, you can document reflexes plus here. You can put it if it's accelerated 3 plus here. So likewise, you can do it in your own way. Are you seeing can you see this slide here? Summary of clinical findings.
We see the tone.
Summary of clinical findings.
No, madam. We see the tone slide. Slide about tone.
Slide of, oh, so it is not moved thereafter. This jerks. Can you see the reflexes slide?
No, madam.
No, madam.
What's this? Are you seeing a tendon reflexes slide?
Yes, ma'am.
Okay. I don't know what's happening. No clue. So, you're seeing tone slide. Now, can you see the power slide?
No, madam. We see the tone slide.
Recording stopped. Recording in progress.
Can you see the power slide?
Yes, madam.
Yes, madam.
Yes. Okay. So power, we have checked different powers from shoulder, elbow, wrist, small muscles of the hand, and we have graded the muscle power. So muscle power grading is this MRC grading that you have already learned, and how to eliminate the gravity. And then, can you see the winging of the scapula? Wing scapula? Can you see it?
Yes, madam.
On which side? Left or right?
Right side.
Right-sided winging of scapula, yes. Then we learned how to do the jerks, biceps, triceps and supinator. Then sensory system you have already learned. And then for coordination, we learned finger, nose test and stydocockinesia. And then, can you see the summary of clinical findings?
Yes, madam.
Summary of clinical findings. So you can do whatever, for example, for right side, tone, let's say left upper limb is has a upper motor nerve type of lesion in our patient. So how we are going to document that? We can say tone normal, right upper limb. Left upper limb tone increased. Then power, you can say these muscle groups, so proximal and distal, and say grade is 5 out of 5. Left side it is 2 out of 5. Then for reflexes, this side plus plus, but the other side triple plus. Or maybe absent altogether, or just 1 plus if it is diminished. So you can build up your own way that you are going to document these things. And then sensory each side, and then the cerebellar signs as well, right? So this is how you are going to document at the end of the upper limb examination. Then, so there are 2 salient questions that you are going to answer at the end of your examination. What is the lesion and where is the lesion? Sometimes what is the lesion will be a bit tricky and will be not, you won't be able to answer that at the end of the examination. But you can say where is the lesion? So the lesion is at C5 level. Lesion is in the median level. Lesion is C8T1. So that is what you have to answer at the end of your neurological examination. The upper limbs. Right? Okay. So neurological examination of the lower limbs. So it's the same. Inspection, tone, power and tendon reflexes. Right? So this is again Colombo Medical Faculty video. So at the end of this lecture, just go and see these videos over and over again. Because I have limited time, so I can't show you, I can't rewind and put them again. So I hope you will go and do these things, see these things again. Can you see the video? Can you see the video?
Yes, ma'am.
Yes, madam.
So here, the inspection lower limbs, the difference is, this is Professor Shyam Fernando, Colombo Medical Faculty Medicine Department. So in the lower limb examination, what is the difference compared to the upper limb? So lower limbs is locomotion, right? Walking. So you have to check the gait first, right? Or at least at the end of the examination, you should do the walking test. So you have to take the gait, right? For gait, you have to check patient walking and then ask them to do the tandem walk. What is tandem walk? That is walking on just one straight line. Heel, tip like this. Okay. So I'm not going to expand this video because it's of poor quality. Let's see whether we can grab the things by seeing it in this way. So here, can you hear this? Let's see.
Now turn around. Go back. Come back. Turn around. Okay.
Just checking the
next
gait
step
of the
is
patient.
to look for the tandem gait. That is, you ask the patient to keep the heel to the toes and then walk on a straight line.
Heel, toe. That is tandem gait checking.
Have you then turn around?
So if somebody has cerebellar involvement, they can't do this. They are falling towards one side.
And if there's any ataxia,
so it is just to check the ataxia, right? So it can be cerebellar ataxia, can be sensory ataxia. So this, if the patient has an ataxia, this is very important test. You know this already. This is Romberg sign. So you can do it in different ways. This is one way. Close the eyes. First open eyes, then close eyes. So now we are showing some examples of abnormal gaits. What is this gait?
Stepping gait.
Yes, high stepping gait. Right? When can you see this? When can you see this? When there's lower motor neuron lesions. So in lower motor neuron lesions, they get what is called foot drop. So when the foot is dropped, you have to clear the foot from the ground, right? And when the bilateral there's involvement, they look like they are walking like horses. All the time, high stepping bilateral. Let's see. So this patient just have left lower motor neuron lesion, and you can see left motor nerve foot drop causing a high stepping gait. See? Right. So this is Parkinson's, right? You can see the involuntary movement of the hand in Parkinson's, right? As well as the gait is very shuffly and very low stride. Hari chuti adi tiyala yanne pani pani, right? And it's very difficult to turn around. And this is bilateral spasticity, right? Severe adaptive spasticity and causing a scissoring type of gait. So this is a patient with cerebral palsy.
After this, we proceed on the examination of the lower limbs from neurological point of view, and we divide that into several components. First, we inspect the lower limbs, then we test.
Can you hear? Or should I tell? Can you hear what he is telling?
Yes, ma'am.
Okay, good.
For muscle power, tone, reflexes, coordination, and then lastly, the sensory examination.
So it is the same thing, right? Inspection, tone, muscle power, coordination, and sensory examination, right?
When you inspect, you should expose the patient.
Expose the patient well.
Look for muscle bulk and for fasciculation.
Fasciculation, muscle bulk, whether they are wasting.
Look for any wasting, particularly the quadriceps, peroneal muscles, and also look for any hypertrophy of the muscles.
So why are you looking for hypertrophy of muscles? You know, fasciculation and wasting, you know, it is associated with lower motor neuron lesions. What is this hypertrophy of muscles? Maybe you have not learned these things already. So hypertrophy is, you know, increasing in the muscle bulk, right? Increasing in the muscle bulk. So some patients with muscle involvement, myopathies, muscle weaknesses, congenital ones, if you have heard about things like Duchenne muscular dystrophy, the muscle dystrophies, myopathies, those patients, they sometimes have hypertrophy of muscle groups. That is why we are looking at hypertrophies as well when you are doing the lower limb examination.
Carefully inspect the soles for any trophic changes or for any ulcers.
Why you are looking for soles? Who get ulcers, changes in the soles, neuropathic ulcers and things? Who get them? Usually?
Diabetes.
Yes. Patients who could have sensory polyneuropathies like diabetes, leprosy. Those patients, they don't have much of sensation distally. Even the hands, sometimes you can see burn marks, right? Because they have so-called, they don't feel the sensation very well, right? ඒක තමයි කියන්නේ ඔය ආච්චිලා සීයලාට ඩයබටිස් තියෙන අයට අවුවේ ඇවිදින්න එපා කියලා. පන්සල් ගිහිල්ලා සෙරෙප්පු ගලවලා අවුවේ ඇවිදින්න එපා කියලා, because they don't know they can get burns, right? Okay. Now going to the muscle talk.
When you test for tone, you should ask the patient to relax. Then you keep your hands behind the knee and flick the leg up.
See? Just keep the hands behind the knee and flick it up.
If the tone is hypertonic, when you lift it up, the whole leg will come up like this.
See, if it's hypertonic, when moving the leg, it's coming like that. Right? The whole leg gets up. And if the tone is low, it's just moving and dragging from the ground or from the bed. And if it's normal tone, it's something in between, right?
And slowly drop down. If the leg is flaccid, you will see that the tone is very much reduced and the whole leg feels very, very flaccid. You do the same with the other. Keep your hands behind the knee and flick it up like this. A jerky movement. It's a normal tone. The other way to test for tone is to keep one hand behind the knee, other hand on top of the knee, and hold it like this and look at the big toe, the movement of the big toe.
While rolling the look at the big toe.
Whether the tone is normal, low,
normal is moving normal. If
it's
it's spastic, a little bit difficult. If it's flaccid, it's moving very fast.
If the tone is increased, then you should look for the clonus. There are two.
Okay. If the tone is increased, then you are suspecting this is upper motor neuron lesion or spasticity is there. Then you have to check what is called clonus. Clonus. So how to check clonus is, just think this is the foot, right? Just think this is the foot. First you do the dorsiflexion. So first you do the plantar flexion and then do the dorsiflexion suddenly. So if there's clonus, there will be a movement, oscillatory movement like this, right? So it is called clonus. Clonus can be seen in spastic lower limbs, right?
Places where you test for clonus, one is the patellar clonus, other one is the ankle clonus.
So there are two types of clonus, but what I'm interested is on the ankle clonus, right?
You make a fist with your right
This is
hand.
patellar clonus.
Keep it behind the knee so that knee is slightly flexed. Then keep the other hand on top of the patella and stretch the spring fold like this. With a sharp jerky movement, you push the patella down and see whether you feel any jerks or clonus of the patella. To test for ankle clonus, again it's important that the knee is flexed and the heel is off ground. You hold it like this and with the right hand you make a quick dorsiflexion movement of the foot. If the clonus is positive,
That is
then you
how
will
it feels
feel
like,
quick
clonus.
this. Presence of hypertonia and clonus are signs of upper motor neuron lesions. You do the same thing on the other side. Test for patellar clonus and the ankle clonus. When you test muscle power, you would usually confine yourself to major muscle groups. You test the 4 groups of muscles at the hip joint, Those are the flexors, extensors, abductors and adductors. And at the knee joint, the flexion and extension. And at the ankle joint, dorsiflexion, plantar flexion, inversion, eversion, and lastly, the big toe dorsiflexion. At the end of examining each muscle group for power, you should be able to grade the power on a 0 to 5 scale. And as you already know, 0 is no power at all, not even a flicker of movement, and 5 normal power. Power 4, there's weakness, but the patient is able to exercise muscle power against some resistance. Power 3 is no movement is possible against resistance, but person can perform the movement against gravity. And grade 2, the movement is possible only when gravity is eliminated. And grade 1, only a flicker of movement. Let's move on to test the muscle power. First we start with the hip. Nansen මේ කකුල දෙට උස්සන්න මට පාත් කරන්න දෙන්න එපා. Ask him to lift it against resistance. මේකත් එහෙම කරන්න. හොඳට උඩට උස්සන්න පාත් කරන්න දෙන්න එපා. Keep it like this. Don't let me push down. Hip flexors. Always compare the sides. කකුල් දෙක ඈත් කරන්න මට ලං කරන්න දෙන්න එපා. Ask him to keep the legs apart and try and resist that. But testing the abductors. කකුල් දෙක ලං කරන්න මට ඈත් කරන්න දෙන්න එපා. Ask him to keep the legs together and you try to pull them apart. You're testing the adductors. මගේ අත මේ ඇඟට තියලා හොඳට තද කරන්න. Ask him to push down. Here I am testing the extensors. Make it table කරන්න. Push down. හොඳට පාත් කරන්න. I am trying to lift it up. When you test muscle power, always compare the sides. Then I go down onto the knee. මේ කකුල නවන්න. මගේ අතට විරුද්ධව තල්ලු කරන්න. හොඳට දිගාරින්න. I ask him to push against my hand. And you look at the muscle bulk here. So I'm testing the knee extensors, that is quadricep. මේකත් එහෙම කරන්න නවල මගේ අතට විරුද්ධව තල්ලු කරන්න. Push against my hand. මේක දැන් නවල. විලුඹ තියාගෙන ඉන්න මෙතනට මට දිගාරින්න දෙන්න එපා. I ask the patient to keep the heel close to the buttocks and I am trying to extend it. I am testing the knee flexors. Then දිගාරින්න එක. මේකත් බලන්න. කොහොමද තියාගෙන මට දිගාරින්න දෙන්න එපා. I am trying to pull it this way and he is trying to bring the heel close to the buttocks. These muscles are the flexors of the knee joint. Let's go to the ankle joint. There are a few important movements there. First, let's test the dorsiflexion. කකුල් දෙක මෙහෙම උඩට තියාගෙන ඉන්න කොහොමද තියාගෙන ඉන්නේ. මට පාත් කරන්න හදන්න දෙන්න. I am trying to push it down. And he is contracting his dorsiflexors and keeping feet dorsiflexed. Plantar flexion. මගේ අතට තද කරන්න. He's pushing down and I am trying to keep feet up.
So in the ward we
Push up.
usually
Pardon.
when you want to do the plantar flexion, what we call is like for male patients, අර break එක පාගනවා වගේ පාගන්න. Do it as how what you do to the break. That is the easier way to do that, right? See, when they are doing the plantar flexion.
Plantar flexion. Dorsiflexion of the big toe. මෙහෙම ඇඟිල්ල තියාගන්න. මට තල්ලු කරන්න දෙන්න එපා. I'm trying to push it down. මේකත් එහෙම තියාගන්න. Hold it up. Don't let me push down. Then let's look at the inversion. කකුල් දෙක මෙහෙම තියාගන්න එකට කරලා. Get the patient to hold the feet together like this and you try to push them in the opposite direction. That is inversion. In eversion, you get the patient to keep the feet the other way around, and you try and bring them together. There are two important reflexes in the lower limbs that you should test. One is a knee jerk and the other one the ankle jerk. Let's look at the knee jerk first. You keep the knee partially flexed with your hand supporting behind the knee and the quadricep muscle well exposed. The response you expect to see is the contraction of the quadriceps with slight extension of the leg. Once you position the knee, you locate the patella tendon. The patella tendon is the hollow between the patella and the tibial tuberosity. With the knee hammer, you hit the patella tendon at right angles and watch for the response. You do the same thing with the other leg. Quadriceps exposed, knee partially flexed and supported, patella tendon located, and the knee hammer hitting the patella tendon almost at right angle. It's not necessary to hold both legs together like this. Let's look at the ankle jerk. When you test for the ankle jerk, again the knee should be partially flexed. The patient should be very relaxed and the foot slightly dorsiflexed. With the knee hammer, you hit the tendon here, Achilles tendon, and look for the response. The response, as you can see here, is the contraction of the flexors here and plantarflexion of the foot. You do the same thing with the other leg. Knee partially flexed, foot slightly dorsiflexed, and you hit the tendon looking for the response. Once you do these two deep tendon reflexes, next you proceed on to the one of the superficial reflexes, that is looking for the Babinski response. To test for Babinski response, you use a blunt object like a key and stroke the lateral part of the sole, starting from the heel and going up to the ball of the big toe. The pressure you apply should be firm. The response you see in a normal person is a flexion of the big toe. If the Babinski is positive, the big toe will extend that like this. That again is a sign of upper motor neuron lesion. Once you do on one side, compare with the other. The best test for coordination is examination again, which we did at the beginning. Let me show you how to do the heel, knee, shin test. Understand? මේ කකුල මේක කරමු. මේකෙන් අපි ඉස්සෙල්ලා කරමු. මේ කකුල උස්සන්න. මෙතන තියන්න ධනිෂ කියලා මෙතන ධාර දිගේ පාතට ගෙනියන්න. You have to instruct the patient to lift the heel up, bring it down on the knee, and then to slide it down along the shin. That's good.
So this test is called Shielny test.
You make sure that he does not slide the heel on the groove here. It should be along the shin.
So it's shin and heel, right? Heel, shin test. Heel shin
You can
test.
improve the
The
sensitivity of
cerebellar
the
sandwich
test
check.
by asking the patient to do the same with the eyes closed. Now, this is an aspect of what That's very good. Make it correct. Aspect of You can expect this test to be abnormal in cerebellar disease as well as in gross defects of the proprioception.
Okay, so we are going back to our slides. So we have what we have, what he has done in inspection part. So they have done gait, inspect the gait, walking and tandem gait. Then did the Romberg sign, and then did the supine position type of inspection like wasting, fasciculations, hypertrophy of muscles, soles, ulcers, skin changes, that type of things. And then tone wise normal. If it is increased, check for the clonus as well as whether it is decreased. And for the muscle groups, check the hip from hip flexion, extension, abduction and adduction. From knee, check flexion and extension. And from ankle, dorsiflexion, plant flexion, inversion and eversion. And from big toe, he checked the dorsiflexion. Is very important because it is very helpful when somebody comes with a backache and a foot drop, and it tells you that it is mainly L5 S1 weakness or major L5 weakness, root weakness if dorsiflexion is positive. And then you have to grade the power. And reflexes was checked, knee jerk, ankle jerk, and Babinski response. Can someone tell me how he checked, with what has he checked the Babinski response? Which instrument was used? Sorry? For Babinski? Yes?
A khaki.
A khaki. It should be a blunt one, right? So, then when you are doing the tendon jerks, one other important thing, especially when you are doing the lower limbs, you have to make them not thinking about that you are going to elicit the reflex, to take away the attention, to distract the patient. So this Genre 6 maneuver, they think there are two different ways that it can enhance the reflex, something that it is going to improve the gamma effect, something that it is going to decrease the inhibition for alpha motor neurons. So I don't want you to learn those things, but Genre 6 maneuver as well as distracting the patient, for me, I think both of them have the same effect, that because it can distract the patient mainly. For example, අපි tendon එකට ගහන ගමන් patient ඉන්නනවා ගම කොහෙද අදයි ආවේ. So when you are talking to the patient, they get distracted. Otherwise when reflex එක ගහන ගැනම හිතන patient voluntarily try to contract the muscle and you can't see the reflex. So it's always very nice when you're talking to the patient while doing the reflex, then you can distract the patient. And for coordination, we do the heel shin test, right? You saw how it is done. And then from the gait as well, you can check the coordination. So that is lower limb examination. And at the end of the examination, make sure that you are inspecting the spine of the patient, right? And you have to see whether there are any deformities of the spine, are there scars, previous surgeries of the spine, and palpate the spine to see whether there is any tenderness. There may be fractures, tumors in the spine. So at the end of the examination, it's important to inspect the spine of the patient. Right? So also here, at the end of the examination, you should be able to say where is the lesion. This is a common peroneal nerve palsy causing foot drop. This is L5 weakness causing L5 root lesion causing foot drop, you will be able to tell after a proper examination of the lower limbs. So this is just to show you hemiplegia, quadriplegia, paraplegia. So hemiplegia is usually, so for example, after a stroke. Say if there's a left side of the cortex, if there's a region of the motor cortex, you are getting right-sided upper limb and lower limb weakness, right? So it is a contralateral hemiplegia. Quadriplegia happens when, in, for example, in the cervical region, if there's a whole lesion of the spine, then all your bilateral upper limbs and lower limbs are involved, which we call the quadriplegia. And paraplegia occurs, it is usually when there's thoracic or lumbar level lesion, where the bilateral lower limbs are affected. We call them paraplegics. Paraplegia. So if there's a cerebellar lesion, then usually when there's a cerebellar lesion, it is the same side is affected. For example, if somebody is walking tandem gait, if somebody is falling towards left side, that is telling you that there could be a left-sided cerebellar lesion. But contrary to that, if the lesion of if there's a motor cortex lesion of one side, the contralateral side, upper limb and lower limbs are affected. The opposite side, upper limb and lower limbs are affected. So this is just quickly going through. I don't have much time. Cerebellar signs, actually I have like passed out of the time. So in cerebellar signs, just you can type these things in YouTube and check what you can see. There are certain signs you can see in these patients. First thing is nystagmus. You have a separate lecture to learn about nystagmus. So nystagmus is a jerky movement of the eyeball, right? When you do the cranial nerve examination, you will learn what is nystagmus. So I'm not going into details. To check cerebellar nystagmus, you're usually moving, ask the patient to look at the finger and move the eyes like this. And you have to keep the finger 30 degrees from the patient. And at that point, you can see the jerky movement of the eyeball, which is called nystagmus. And usually the fast component, fastly moving the eyeball, is towards the side of the cerebellar lesion. And you already know the ataxic speech. I told you in my lecture of ataxia, when somebody is scanning while speaking, parliamentu, so that is scanning. They can't tell it smoothly. When the speech is ataxic, that is in cerebellar lesions. And positive finger nose test that you have already learned. So if they have a cerebellar sign, they are fast pointing, going here and there. And then dysdiadochokinesia, we learn dysdiadochokinesia, and which can be defective in cerebellar lesions. And then they can have what is called intentional tremor. So what is intention tremor? So if somebody has tremor throughout, like in Parkinson's, they have tremor all the time. When they are walking, they have tremor. When they are resting, they have a resting tremor mainly in Parkinson's. But in cerebellar, if they are going to do something purposefully, then they are getting the tremor. For example, when you ask them to touch the nose or your finger, then they develop the tremor. They develop the tremor, right? Then චූටි බෝලයක් දීලා කියනවා අතෑර පෙබල් එකක් වගේ කියලා මේක අල්ලන්නේ. ඒක ළඟටම ගියා they develop tremor, which is a cerebellar type of tremor. And then what is rebound phenomenon? They are getting what is called rebound phenomenon. It is like හිම දෙක තියන් ඉන්නකොට the bilateral hands like this, right? Somebody is trying to press this downwards. Press the hand downwards. Bilateral hands, right? So what happens to us usually, we are going down like and coming like this. So if they have cerebellar dysfunction, it happens like a rebound. When somebody presses these hands, then it comes up like this, right? So you are trying to press the patient's hand downwards like this. It's coming up like this. That is called rebound phenomenon. And then they develop, because of hypotonia, they have cerebellar patients, they develop what is called pendular knee-jerk. So when you want to elicit pendular knee-jerk, just sit them up in a like taller chair and just the leg is dragging down like this, right? Not a small shell like this, like maybe on the table. And then when you tap the knee, knee reflex, right? You can't see it properly. When you tap the knee like this, we usually, if this is the knee, if this is the leg, it is going like this and coming down like this, right? When the knee jerk is elicited. But these patients, it's a pendular knee jerk. So the leg is moving like this 3-4 times and then only stops, right? Just check the videos in YouTube. So when you hit the knee jerk for the tendon, it is the quadriceps tendon, the leg starts moving like this and then stops. This is called a pendular knee jerk. And you learn heel shin test, and then you learn poor balance at tandem gait, and the wide base gait that they have, and the Romberg sign you already know. I showed you videos during my lecture. So these are some videos which I'm not going to show you now. You can check them in the YouTube. And when you're checking the nystagmus, as I told you before, you have to keep the finger 30 degrees and look for the jerky movements, right?
¿Sabías que sí es posible cambiar todo lo que no está funcionando en tu vida en Access?
I'd like to get you to keep your head still, if you don't mind. You look specifically at any, there's no evidence of closest. No spirate breaths, and the pupils are equal. That's the nystagmus.
So can you see the nystagmus?
There, you can see more mark on the left side than the right, which is the big hint here as to whether there's an underlying right side of the ionola.
So he's keeping it 30 degrees.
More obviously,
so that is
very marked inside the right eye with the failure of adduction of the left.
How you can check for the nystagmus, right? Right. And you know what is this diadochokinesia? That is rapid repetitive movements and rebound phenomena and pendular reflex. Okay. So today we learned how to examine motor system, and then we learned how to do the cerebellar examination. So I advise you to see these videos over and over again, and then you can get an idea how to do these things. When you are starting to do your clinicals, then it's very nice if you can do these things for your patients over and over again, because you don't do much of neurology examination in patients. You usually do cardiovascular, respiratory, abdominal examination for all the patients. But you can learn only by doing these things for your patients, neurology examination as well, for each and every patient that you need, right? So we learned today upper limb examination, lower limb examination, and how to do, what are the signs, positive signs in cerebellar examination when the patients have cerebellar lesions. Do you have any questions? Because we are running out of time. Do you like to watch the videos in there? Like you watch the cerebellar science videos, and I advise you to check, see those videos, upper limb and lower limb examination videos, right?
Recording stopped.
Okay. Okay, then have a nice day. Thank you for joining. If you have any questions, you can text me, you can send me emails. I can give you my email address. Some students are sending questions. I think it's 43, third batch students are sending questions. And I can give my email address to your batch trip, so you can email me if you have any questions, right? Okay, thank you.
Thank you, madam.
Thank you.
Thank you, madam.
Thank you.